So, welcome back from break. Did you enjoy that nice, spacious break? I know I did, yes. So I'm going to start by asking our panelists to briefly tell us about your ministry context and how the presentation by Dr. Stephanie, the conversation that she and I had, how it's relevant to your ministry. So a little bit about your ministry context and how you found that presentation to be relevant. I need to get us started.
No. Good morning. I'm Rodney Lynch. I serve as pastor and executive director of the Baptist Student Foundation at Purdue University. So I'm in a campus ministry setting, serving young adults as they are formulating their own identity across ethnics, cultures, faiths, and generations. Speaker to my left here, this resonated with me in a couple of ways, but I'll start with this. Cornel West wrote in his book, Race Matters, back in like 93, he talked about nihilism in Black America. That sense of value and hope, love, worth. But what I have realized, and this is pre-COVID, by the way, that there's nihilism going on college campuses, where young adults just don't feel that they are worthy or have any value. And so, because of that, my first 4 years on campus, again, pre-COVID, I heard of potentially about 4 or 5 completed suicides a semester. Those are the ones I heard about. Right. They don't really advertise when students complete suicide. And so this is prior to COVID. This is pre-COVID. That context is important. So when we go post-COVID, and the spike has risen, not just in Black America, but just on college campuses. So I'll just say that for now, and that's why this resonates with me so dearly.
Thank you. That brings it right home, doesn't it? Yeah. Thank you, Rodney. How about you?
Good morning, everybody. My name is Gladys Rodriguez. I'm coming from the Corporación Milagros del Amor in Puerto Rico, said CORMA. CORMA is an organization of 26 years serving the community. We serve primarily homeless people. And we have funds from HUD. Right now we have 42 people homeless in housing through our programs. And we serve youth through our other programs, visiting them in the schools and the community, providing them with skills and coping skills to their mental health situations and problems. We really have to think about the situations that we have in the island. A study that you can find in the National Library Medicine page, you can find that the 27%, according to that study, the 27% of the Puerto Ricans, the study explained that has higher rates of major depressive disorder than the people in the States. We have a very bad situation in the island, as you know. 6 years ago, we have been hit by the Hurricane Maria, that it was a terrible hurricane that impacted the island, leaving us without electricity, without food, without too many things for months. You have to think about that, live without electricity in darkness for months. It's terrible. In my personal situation, I has been for 7 months without electricity at home. And I live in a mountain where the people are very poor. And I was visiting all the streets, helping the people. I worked for the Red Cross on that time. And they provide me with solar lamps, and I provide that to the people there. So we had, later of that, we experienced the earthquakes in the island, and the south and west of the island was very impacted by the earthquakes. It's very difficult to deal with the pressure of the earthquake after the hurricane. Right now, 6 years ago, from the Maria hurricane, our government received $20 billion to restore the island, and only a fraction of that money was used for support to the island. We have a government that is very corrupted. We're not, I have to say that because it's real. And the money that should go to education, to health, and to other programs for service is not going. Our health system is not working. If you go to a hospital, I was in the hospital 3 weeks ago, and I received the, how can I say, the suero. Can you help me, Abigail? The IV, I received it stand up on a hole because there are no space in the hospital. And I was sick, but I am waking up in a home to receive my medication. So we have a health system. If you call to a doctor, you have to wait 6, 7, or maybe a year for an appointment, okay? So let's think about how many stress we have, including so other things that could be happen. You see the news, and there's problems with domestic violence, criminality, etc. So if we have to work with youth, we have to work also with parents, with the family, because it's the mom and dad are having this kind of situations and are depressive and are experiencing the problems, they can deal with the youth. So thinking of that, we at Corma we are right now working on a program for help parents to take time to help them to receive coping skills and help the youth also. We are visiting the schools, and we are working with parents also. In one of the last workshops that we provide to a public school in Caguas a few months ago, students said, why another organizations don't do that? Because we do not talk and talk and talk. We put the students in activities so they can understand and they can, work with the information that we are providing. We are so happy for the results that we have in our programs. Students are going to us to ask for support. In addition, people from the community see Corma as an organization to receive support. We receive so many people visiting us asking for support because they want to suicide. So the social workers immediately call, trying to, talk with the person, and then call the ambulance, and we help the people in the process to be admitted in a hospital, in a mental health hospital. So we are doing our job, we are doing our work, and if you need something from me, another
this year. And it was actually founded from a student at Colgate Divinity School who did a needs assessment on the community and realized that it was a highly impoverished neighborhood and that they needed food there. So she started a food program, and hence we still have our lunch that's served Monday through Friday for anyone in the community, no restrictions. And I've been in Cameron 2 years. The first week I was there, two young ladies walked into my office and told me about sexual abuse that they were experiencing at home that they hadn't been able to tell anyone about because they were afraid to. And so immediately I started to sort of take notice a little closer as to what was really happening in that community. And I read needs assessments from the county, the city, Department of Social Services to sort of prepare myself for what I would be going into. But this neighborhood has the highest child poverty rate in Rochester. The oldest community is Northwest Rochester. Last year there were 81 homicides. They only occurred in two communities. One was the Northwest and the Northeast. So we're in an area where our children are exposed to violence at a high rate. So when these two, going back to the two young ladies, I began to sort of hang out with the kids because we have an after-school program. And going out on the playground with them, I was standing there that day and I looked across the street and guys were just selling drugs, cars were coming by, and I thought, hold up, the mother in me says this can't continue because we know the element of violence that would come along with the drugs being sold. So I went over there and I said to them, hello, how are you doing today? And one young man said, hello, and in a very friendly way. And then I said, do you have any sisters or nieces and nephews? And one of them said, yes, ma'am. So I knew then that one I could talk to. And I told them about the kids on the playground and could they please go somewhere else, not stand directly across the street from the playground. And so they left and they have not been back since then. So again, I knew that the community could be a resource for us, even though it was riddled with all of these social ills that we talked about. And so from there, we started a street outreach program, just my social worker and myself. And we decided to walk the streets, tell people about Cameron, and ask them what they knew, how could we help them. And so we started that. Before we knew it, we're up to 23 groups now. And that was in 2021. We have a medical doctor that goes with us. We have nurse practitioners. We work with Rochester Regional Hospital and Trillium Health. They both have the mobile medical vans that go out with us. We take our wagons with a lunch. We take clothes, shoes. We take hygiene products, anything free that we have or that we have excess of that we can take out to the community. We literally go where they are. And so that has made a huge difference. From that program, we've had people come in and say, I'm ready to go to treatment today. And so we've been able, so far this year, we've sent 4 people to treatment. 2 of those people have contacted us and said, we're doing fine, we've made it. One young man finished his program, is working now, and comes by periodically to say hello. So we know that street outreach can be a very powerful tool. Also in helping people who have mental illness, we see a lot of that on the street. Homeless population or unsheltered, we say. And then we have sex workers. We've been able to work with sex workers, bring them into Cameron. We had a day of beauty for them where we had a lady that volunteered to do foot massages. We were able to talk to them and tell them about our services. Hopefully that will lead them to come in. And so far one of them has come in to go to treatment also. We had a program with the nurses from the University of Rochester, a tea party for the ladies. And they came in, had tea, and the nurses talked to them about women's health and wanted to know when they've been to the doctor. Very non-traditional ways, but also showing them that we care, that our ministry is the work that we do, and that we're not all sitting in the offices waiting for them to come to us, that we want to take those services where they are and offer them the help we have. So our project from ABHMS is the Kaleidoscope Project, and it's for our youth program. We expanded our services. We had about 50 kids at Cameron. We're K through 12. We have a teen center. So a child can come to Cameron in kindergarten and stay until they're in high school. And we added this year another site at a charter school. So we're serving this summer we served 120 kids. Right now we're serving 110 kids. So we've really expanded the footprint of working with children and of course the parents. One of the huge hurdles for us when those young ladies told me their situation they had was that we had young people who were waiting for mental health services for over 6 months and no appointments in sight. Often those appointments were canceled or the therapist had left and gone to another agency. So we knew that we needed to be proactive at Cameron, and we were fortunate enough to work with the Presbytery of Genesee Valley, ABHMS, and we got enough money to fund our social worker for the youth for 2 years. And so she is a licensed LCSW, and so she is actually on site every day with our kids, so when situations arise, we can handle them directly right at that moment. With the violence in the neighborhood, right in front of our building, we've had probably 4 homicides already over the summer. We've had one child whose father was shot while they were walking to the store and he fell back on this baby, 6 years old. We found a suicide note in the children's area laying on the floor that one of our young ladies had written. We've had NPR article where one of our kids, 6 years old, told the reporter, if you don't know about violence, I'm going to teach you now because I don't want you to go through what I've been through at 6 years of age. So this is just a snapshot of the violence that the children have there. And so we deal a lot with trauma. We talk about adverse childhood experiences, which could be any number of things. There's a score that you can get up to 10 on that assessment. 4 and over is a high score, which means that even as an adult, these same issues can catapult into other things, even health-related issues. So we have our work cut out for us, and we have somewhat stepped up to the challenge as much as we can. So we are dealing with that with our young people. So I can certainly appreciate our speaker this morning talking about the trauma. We even had the kids walk from school down to our building. Our staff goes up to get them because our street dead ends into a school. And so they were coming one day and a young man was shot getting off the school bus. So we deal with those things. Unfortunately, some of the kids have normalized violence and they'll say, oh, Miss Olivia, that's normal. Everybody has a gun. And so you have to combat that and let them know that no, baby, everybody doesn't have a gun. But when you're in the store and you see someone in line pull out their gun and sit it on the counter and then get their money out of their pocket, then that's what makes them think that this is normal. But I say go to Henrietta or go to Brighton, some of Pittsburgh, some of these other areas, that won't be acceptable. It's here because it's in this neighborhood. So you can remove yourself from here through your education, or if you have a rich uncle that dies, it leaves you a lot of money. but we do fireside chat on Fridays. I do that with them, and we talk about what's happened in the community that week. So the open communication, our social worker who's specifically focused on the youth, these are some tools that have helped us deal with some of the trauma that our young people face, and parents also come in and can see our youth social worker if they desire. So thank you all for having me.
I'm Tansy Cadeau, and I volunteer as the Director of Care and Counseling Department for Korean Baptist Churches in the USA. In America, we have more than 100 Korean churches and about 30,000 members. And so in our denomination, we started addressing the issues of mental health in 2020, and ABHMS was right there with us from the very beginning. And regarding what Dr. Ewing addressed today, you know, when she talked about the definition of trauma, exposure to danger of life-threatening situation, that just resonates with me. Because the project that we got the Palmer Grant for was called Mental Health Matters. And so we provide opportunities for all our current churches to have learning and conversation about mental health. So we talked about mental health and identity, substance use, grief and loss, trauma, spirituality, you know, depression, suicide, self-harm, and so on. And, you know, just as she was saying, like exposure to life-threatening situation, and if you walk in the shoes of youth and young adults of current kids, their life has been nothing but unsafe. And so to understand their experience, you sort of have to journey with them. So prior to arriving in the United States, you know, fleeing from their villages, they have directly either witnessed or experienced life-threatening situations. So I still remember this story that this young man told me. He's like, you know, Tansy, I was about 10 years old, and the Burmese soldiers just came in and they grabbed my grandfather, and then they started carving his face with a knife, and then rubbed salt and pepper on it before they actually shot and killed him. Talking about gun violence, right? So he was like, I just couldn't do anything. You know, there was absolutely nothing I could do, and I just watched. And then we moved on. Nobody talked about it, right? And so that's where it started. But then the next destination is a refugee camp. In a refugee camp, this is the common theme that you heard from them. I'm a stateless person. There is no recognition of my existence. I don't belong anywhere, right? So there's that identity issue, right? I mean, that who am I? I don't belong here. I don't matter in a bigger scheme of things. And so that's where they came from. And then arriving in the United States, you know, a whole host of traumatic experiences follow, right? I don't speak the language. That's what they would say. I look different. I speak different. I can't defend myself. You know, bullying is quite a bit. And when we talk about racial discrimination, you know, they usually get to live in an unsafe environment, and so got attacked by gang members. And so even in Phoenix, in our church, at the beginning, a lot of our kids were just fighting with gangs like every day, and parents were almost involved. And so we stepped into the situation, and nowadays things are way much better. But here is again, like, I don't fit in here. It's just not safe being at school. I just want to hide and isolate. And, you know, Dr. Ewing mentioned that isolation, withdrawal is a big piece of a symptom, you know, of mental health issues. And then, unfortunately, at home, are they safe? Not necessarily, because they're dealing with their parents and processed trauma or trauma responses, or unhealthy coping. So it would be common to see domestic violence, issue with substance use, right? And if you're the elder kids, you're parentified, right? You take care of your kids, and then some of these kids, they don't speak English so well, they don't speak Korean so well. There's that communication issues going on at home as well, right? And then one thing that I learned actually quite recently was the church environment that you talked about. Because, you know, in our church, young people are expected to serve. We don't have custodians. Most of the cleaning and all of that is done by our young people. And so you're expected to sing, look good, make your parents look good, you know, and do all these spiritual activities, so to speak. But then never explain why you're doing this, or that we're grateful to you, right? And so this is unintentional, but it becomes performance, right? And that how there's higher expectation existing with a higher level of judgment as well. Because if you're judged based on how well you perform, and then you're praised, the praise that you get is highly correlated with how much good you do, then the church may be unintentionally providing this unsafe space for the children as well. And so, with your help, we were able to talk about these things with churches, parents and leaders and pastors and children and youth. And it's been enlightening. Of course, there's so much to be done. However, I believe that, together with ABHMS, we have embarked on a journey of healing and hope, so I'm really grateful. Thank you.
Wow, yeah, can we, that's awesome. Thank you each for the testimony about the work that you're doing. I'm hearing so many challenging stories. I'm also hearing the incredible practices that you're putting into place to approach these challenges in a really holistic way. Stephanie, can I ask you to reflect on what you've heard, and then we'll give the, yeah.
Okay, there we go. Yeah. So a few things. The pastor who spoke this morning talked about ordinary people, or the song was about ordinary people, and that struck me as everyone was talking, that we're just all ordinary people, and we're trying to do God's work and to do our best in really difficult situations, and we're all doing it. I mean, it's just amazing the things that you were all talking about in terms of the programs that you're running. I think the other thing that stood out to me as a clinician and a researcher, which I didn't get a chance to mention, so the only really comprehensive theory of suicide has three components to it: thwarted belongingness, perceived burdensomeness, and acquired capability for harm. And it's really the first two that stand out as the biggest risk factors in the research. So a feeling of thwarted belongingness. I don't belong anywhere. I don't belong at school. I don't belong at home. There's a nihilism. I don't fit in. There's nothing here for me. And I'm also a burden. Somehow I'm a burden. Maybe I'm not performing up to expectations. I'm not living up to what people expect of me. I'm just a burden. When those two things are both high in youth and in adults, it puts them at higher risk for depression, suicide, all of these things. And everything you're describing, like that's what I heard. I heard that you're providing these spaces of belongingness and providing these spaces where youth and parents don't feel like a burden, and I think that's amazing. So, yeah.
Thanks, Stephanie. Yeah, amazing work that you're doing. Let me ask if you can talk maybe about some intersections. I'm going to ask each of the panelists to speak to something that you heard from the earlier presentation that you feel like you can either immediately put into play in the work that you're doing, or that you know you want to learn more about so that you can put it into play. So you can do either or, something that you're immediately going to go back and put to work, or something that you want to know more about. And if we have time, if there are I want to know more abouts that Stephanie can address briefly, we will do that. So who would like to go first? I won't put it up first unless he volunteers. Anyone?
Start that in the stuff.
I think Dr. Ewing talked about stigma, right? And that is something we can go home and share right away, that normalize mental health, right? If I have diabetes, cancer, nobody is really criticizing criticizing me, but if I have depression and anxiety, then something is totally wrong with me. And so normalizing mental health in our communities, that it is okay, that you're struggling with this, and we're here with you, and that's something we can all educate ourselves, and then we can all try to lessen, decrease, maybe even get rid of stigma in our own home, in our communities. And the second thing that I would like to implement more is the attachment piece that Dr. Ewan talked about. Because a lot of us are suffering from insecure attachment. We don't have healthy attachment with our parents. We don't have healthy attachment with our church, our leaders. And I'd like to find out what does that look like for the population that I work with, for the Korean refugee churches. What does secure attachment looks like? And that what needs to happen. So actually, in a couple of weeks, I'm going to be going to Minnesota, and you just gave me the title for my presentation, which is attachment, and just having this conversation. Like, what does it mean for you when you feel safely attached to someone? And I think that that really is going to counter work against this sense of danger, a sense of not feeling safe, and that shame, right? Because shame going too long, too far turns into self-loathing, and which is a symptom that could potentially culminate in suicidal self-harm. And so every time we're providing that secure attachment, even if for a moment, that is where we're giving hope. So thank you.
So I was really struck by the suicide rate for males. I knew that the suicide rate was increasing, but I didn't specifically know that about males. And it was so timely because we are now working with probation and parole in our area, and we will actually have young men who will be coming to our teen center as part of community service, and then we'll railroad them on into the program. But immediately when you were talking, I don't know if any of you have seen the documentary on Khalif Browder. He was the young man in Rikers Island who was incarcerated and just treated horribly through the whole system and ended up committing suicide. And even now it's very painful. But I thought about that, and then I thought about these young men who say, talk about being incarcerated as if it's a badge of honor. Oh yeah, I was down with so-and-so, and I've been to that prison, and man, that's no big deal, and so all of that was kind of running through my head as you were talking, and so now I feel that I've got an extra challenge ahead of me to also pull that piece in and see where these young men are, along that line. So thank you for that.
I am impressed about this phrase of normalizing mental health situations because I think that we need more coping skills in the community to deal with that. Personally, too much people ask me, you are dealing with so many things at the same time, with so many situations, so many problems. Why are you laughing? And why are you like this? But I think that I am strong in this area, and I am trying to work with the people and help them and be empathetic. But I need to be strong to help the people. So I sometimes like to enter in the soul of the people, to let them know, to be, let me help you, and not too much people ask for support, ask for help. So I think that God provides me that strong that I need, and we need as churches and as an organizations need to be more to transmit that faith from God and that strong feelings from God to the people. I know that it's not easy, but as I told you before, for youngest people, I was talking about this with someone. We are using peers. We are using internship students to reach the youth people, because if I use our pastor, maybe the young people do not like to talk with him. So I need to use peers to feel them identify with the person who is providing them with that support and that information. And with homeless, we also use our social workers. They made a contact and they established a good bond with the participant, so the participant is able to go to the social worker when he feels bad. We receive calls from, for example, from a homeless that say, I will suicide on this afternoon. And the social worker started to talk with him by phone, started to let him know that I am here to help you. So let's come here, let's talk, let's drink a coffee, let's talk. Don't talk about this. So the person feel comfortable. We have 42 people in housing, but most of them has mental health situations and drug abuse. Recently, one of our social workers, 2 years ago, told me we need more training about drugs. The drugs that the people are using right now, we don't know what kind of drugs are, because there are new drugs, there are synthetic drugs that have destroying their minds. So we need to be with the correct information, and we need to be trained our personnel frequently to be with the information that is new and help the people that we are serving.
Thank you. I'm just going to put out there before I hand over, Ronnie, 988. Please write that down. It is the new National Suicide Hotline. We teach our children and youth 911 from a very early age. 988. If we can be promoting that in our ministries, in our churches, as a resource for our young people and our grown people. 988 National Suicide Hotline, 24/7.
Thank you. First, Stephanie said something kind of funny earlier. Not funny, but like 50% of attempted suicides after having an argument with a parent. If I argued with my parent, it'd have been homicide. I had no concept of arguing with my parents at all. So that was shocking to me. It really was. We argue about the switch that I brought that's too thick or something like that. It was brutal, but I turned out all right. But then, my dear sisters to the right had reminded me of approach, especially when dealing with young people. It's not really what you say, it's how you approach them. I've realized that young people want the same respect that I want. And even the way I dress is to be approachable to young people, right? And so I think that's important to remind them. Then I was reminded, Stephanie, about trauma and vicarious trauma. And so I refused to watch the George Floyd's modern-day lynching on national television for the whole 9 minutes and plus seconds. I just couldn't watch it because of the trauma and re-traumatizing myself. So I don't watch those videos in its fullness. But then also there's epigenetically, there's historical and generational trauma as well that we carry in our bodies. Resman Mendelssohn talks about that in his book, My Grandmother's Hands, mending pathways of racialized trauma and mending our hearts and bodies. And so when you have this, we call that what's called nihilism in Black America, and then you have these traumas that we carry in our bodies intersecting. These students are coming to Purdue University from all over the world. Therefore, in what ways do I help them tear down these barriers that they're coming with in the first place? Because we have this sense of we just don't have no acceptance to difference, right? Don't take for granted this white nationalist and Christian nationalist movement. They're synonymous, and very, very real. And it's not just white people that believe in it. And so when we have this intolerance for difference, what is my role going to be when students come from deep Indiana, Kentucky, ain't never been around a Black person their entire life? Or people coming from Gary or certain parts of Chicago, ain't never been around white people or anybody outside of it. They come to Purdue, and I have a responsibility, and I tell other campus pastors, because every religion is represented there, that we got to figure out a way to bring these students together and tear down these walls. And so what the grant has done for me is it has helped us to bring people together across ethnicities, cultures, generations, and faiths together to just share who we are. We're reclaiming that oral and oral tradition of storytelling. I think it's very, very important. I'm not coming to condemn you. I'm coming to hear you. What's your story? How'd you get here? And then as we share our story, guess what we find? We have a lot more in common than we have different. I learned just a couple of weeks ago talking to another pastor. We grew up different cultures, different experiences, and he shared his growing up, and it was almost identical to the way I grew up. So that tells me I wasn't alone in that experience. And that's what we need to do. I mean, we need to, first of all, the church needs to stop being so judgmental. Because every time we condemn somebody to hell, we might beat them there. I'm just saying. So rather than being condemning and judgmental, we need to be more understanding and compassionate. Compassion through the lens of being in that person's shoes, in that person's story. Because our stories is what connect us. Our stories connect us. So that's what we're doing through the grant. And then finally, and I'll wrap it up with this. Where's my hope? It's a good question. I'm glad you asked. Although I refuse to watch the George Floyd 9 minutes lynching plus on national television. Post George Floyd, what I watched was a movement that was all over the world. It was intergenerational, it was intercultural, it was interfaith, and it was global. The energy of young people, Black Lives Matter, and the memory of older people, civil rights movement. Together, that's where my hope is. Somehow, some way, I'm hopeful that we are coming together at Purdue University to tear down these walls that separate us. The energy and the memory together is where my hope is. So y'all get on board with us. And let's come together and tear down these walls that keep us so separated. Amen?
Stephanie, I'm going to invite you to speak to mental health as part of health.
Sure, yeah, I think everybody has kind of commented on that in this last segment. I'm gonna need help with my scripture for a minute, but I know there is, I can't remember where, but about the role of physicians, right? And that God gives physicians and therapists and the tools and the knowledge to help build coping skills and to assess for mental health. And so that we need to both pray and also turn to the knowledge about the effects of trauma on the brain, the effects of trauma on the body, the accumulation of trauma and what that does, and stress and what that does, and what we know from the knowledge that God has given us in terms of healthcare professionals on how to help with that. So building coping skills, building safe relationships, and how that can counter, from a health perspective, the effects of trauma on the body and brain and mental health. And what you and I talked about this, I think, in our conversation, our attachment to God and our safe, secure relationship with God is the most miraculous coping skill that we have. But there are others as well that and doing both in conjunction with each other and using prayer to pray for the providers who are helping, for the therapists who are helping, that they'll use their knowledge to help our health as well, and our children's health as well. I think that's my overview.
Thank you. I just want to add to that. I see your hand, Reverend Chris. Young people are leading the way in breaking the silence about mental health. I don't know about your congregation, but in our church, we invite the congregation to stand up with their prayer requests and praise report. And we have a young woman in the church who, at least once a month, confesses her struggles with depression and solicits the prayers of the congregation. And the congregation comes around and says, oh, do you need a referral to a good therapist? I know someone who can help with that. We're going to come visit you when you admit yourself to an inpatient program because you know you're not safe. Our young people are talking about it with each other, and they will lead the way in modeling for us how we can start talking about it. And when you know, sometimes adults in my congregation are now standing up and saying, I'm carrying a lot of anxiety right now. My grief is just drowning me right now. I am really struggling with stress at work. And all of a sudden, we are talking about mental health. Right next to the person who says, my niece was just diagnosed with this. My aunt just was diagnosed with this. These are health concerns, and we all have mental health as well as physical health. Reverend Chris.
Yes, I just wanted to acknowledge something very powerful that Reverend Lynch said. During the biennial, we were discussing some of these issues of trauma, and I found it instructive and interesting that the physicians were discussing how it impacts us physically, not just in terms of anxiety and whatnot, but how trauma actually has the ability to change DNA over generation. And they were able to study the changes, not just in terms of how you feel, but literally the DNA changes across generations through generational trauma.
Thank you for sharing that with us. Thank you. So that's the epigenetics.
So as we were talking about the peer education model where young people help each other, our social worker has boys group and girls group. And so if the kid, someone says, oh God, my anxiety is really getting me today, then another kid will say, take a deep breath. You know, and so you know it's working. Or if a conflict arises and they get in it and want to settle the conflict, you know, peacefully and not put hands on each other or make threats, you know that it's working like a well-oiled machine. And so that's what you want when you're in this process of working with them is to have them actually come to agreement that this is a better way for me to do this, and they listen to each other more than us old folk. They don't want to hear from us. They want to, so the peer model is very strong.
I just wanted to say, one thing, so, in the back that we were saying it up here, but that is epigenetics, that's the definition of epigenetics, so the trauma impacting your DNA, and then that, whatever happened, there's all sorts of processes that can happen that are affecting you on a brain level, a cellular level, a cardiovascular level, all that actually can get passed down, as you were saying, epigenetically, so that was one thing. But I think the other thing, it was something that you just said. Oh, I know what it was. So talking about it, I think actually, Rebecca, you were talking about this. There's studies that show when you're actually monitoring brain activation and you show individuals distressing pictures that might elicit feelings of sadness or fear, that if they can say out loud, I'm scared or I'm sad, that it decreases the brain activation. So being able to say it, actually just to say it in church when you're saying, like that in itself brings down stress activation. So.
We are a people of the word,
Yeah.
right? That preaches. That preaches right there. God, the word becomes flesh, and the flesh is affected by our word. That's really powerful. Where are we on time? We have time for another question, or are we ready for lunch?
Kerwin the final word, shall we?
Oh, yeah, Kerwin.
Okay, just practically, Dr. Ewing, you talked earlier about when the pandemic hit, there was this like backlog of clinicians, and then we know about the costs of healthcare and mental health care. It's all great to say mental health care, yada, yada, yada. However, what can church bodies, denominational agencies, or regional bodies do to fill that gap? Because if I need health care, but I can't afford it, it's no good to me. Just thoughts on that.
It's something that brings me a lot of sadness, and that I pray about. And I, as a therapist, and an individual therapist, I can help one family, or I can help one child at a time. But our healthcare system is in many ways, our mental health care system is in many ways broken. We don't have enough people trained, and we don't have openings, and so I hear that concern, and I don't know what the answer is because it feels so vast sometimes. But I think what we were talking about earlier, and all of these programs here, and the models that they're providing, they are places that we can look to for how we can fill the gap, right? And if we can make our places of worship, our churches, the safer spaces, places where people can talk, places where people don't feel judgment, but they feel belongingness, and they feel I'm not a burden. This is a safe, warm place that I want to go to as a kid. Then I think that does a lot to fill the gap.
Yeah, thank you for the question, for the acknowledgement that there are no easy fixes. I also heard something from Olivia earlier that you did community research. Like you started to actually find out what the community needs and what the community has to offer. I think that as faith leaders, we are taught in seminary, if we are taught at a good seminary, the importance of referrals, where I must end and someone else must begin. So having a good referral list, knowing those resources, recommending 988 as a 24/7 trained, skilled. I'm going to talk with Dr. Ewing after this about a program that I've heard about, and I'd like to get her feedback on before we offer it to you all. But we are also looking for those resources to be able to offer all of you so that you are better equipped to meet this incredible need. And we may be reaching out to those of you who are already doing it well, for best practices.
One community gap, I'm wondering whether you guys use, but mental health first aid. That has been very helpful for us.
Yeah.
Because we are not, we can't be an expert, but then now actually our community leaders are training to become a coach so that they can teach mental health first aid.
Laura, you read my mind. I didn't want to put her on the spot, but that is great testimony to hear that you're using it and it's
We are
working.
using that,
And
and
you're
that has
familiar
been
with it?
Yeah, I'm familiar with it, it has good evidence behind it, and it falls into that peer support model as well, so yeah, definitely,
All right, stay tuned. We will let you know when the first training becomes available.